myself, Mona Ganunia, and Dr. Michael Horberg are going to be just talking with you today about HIV care and specifically primary care for patients with HIV. So I'll start quickly by just introducing myself. I'm an infectious disease physician with the Mid-Atlantic Permanente Medical Group, and I've always had a special interest in HIV care. And I'm also associate medical director for operational excellence with the Mid-Atlantic Permanente Medical Group. And I have the honor today of having my colleague with me, who is well known to certainly the HIV community, Dr. Michael Horberg, who's also specialist in infectious disease and specifically HIV, and has dedicated many decades now to not only HIV clinical care, but also research. And he's a champion for patients with HIV. And we're really excited to be able to talk with him today.
Thanks, Mona. Thanks a lot. It's interesting. As we're in the middle of a COVID pandemic, and you are so leading that effort within Kaiser Permanente Mid-Atlantic states, it's interesting to reflect that we are actually in the midst of two pandemics. We should never forget that for the past 30 plus years, or now close to 40, we have been involved in a worldwide pandemic of HIV. It's a little different. The dynamics are different. But for many communities, whether they be African American, young gay men, transgender population, this is the COVID may be a temporary condition, but this has been the long-term pandemic for many, many years. And so I think it's really important that you and I, we've been championing this for so long and doing so much. And the disease has just so incredibly changed over the course of these 40 years. It is not what it was. And therefore, it is so essential that our primary care colleagues, as well, of course, as our infectious disease colleagues, really understand the importance of the care and the care they deliver.
Yeah, that's really well said, Michael. And I'm reflecting on how I got on this career path. I remember being in medical school, and at the time, there were what we call AIDS hospices. And as a medical student, I actually volunteered at an AIDS hospice and became extremely interested in the care of these patients, which was very complex at that time. But can you tell us a little bit about how you came to this career path and why you chose specifically your expertise in HIV?
Thanks so much. Thanks so much for that. Well, first off, when I first started med school in 1981, it wasn't per se a topic. It was a last lecture as part of our microbiology rotation. And at that time, it was called GRID, gay-related immunodeficiency. In fact, in 1985, when they discovered the actual virus, the HIV virus, that's actually the year I graduated med school. So really, my whole professional life has been the story of HIV. As an out gay man, when I started in private practice in Chicago, friends of mine were getting sick and dying. And AZT just wasn't sufficient therapy. So in fact, I sought out, and always had an interest in research, I sought out opportunities for them for clinical trials and stuff. And then when I decided to move to the West Coast, San Francisco, I actually led the HIV program for our Silicon Valley locations, and then eventually for the region, and then eventually within KP nationally. And when I came out here, of course, where here in Mid-Atlantic, DC, we should never forget, has the highest prevalence of HIV than any state or city in the nation. And so it's so crucial that we lead this by example, how to attack and combat the pandemic.
Thank you. Yeah, and I know here in Mid-Atlantic, one of your major roles is leading the Mid-Atlantic Permanente Research Institute, or MAPRI. Can you talk a little bit about that work?
Well, thank you. I always love to talk about MAPRI. We have about 10 scientists. We do multiple areas of research, including clinical trials, including now clinical trials in HIV also. HIV, STDs has been one of my key areas of interest, but we have a very robust program in health services research, oncology, cardiovascular disease, transgender health, um, and of course, I'm forgetting some maternal child health, and now also pharmacologic care, and really trying to answer the questions that our physicians have, as well as the rest of the care system. It's so great being able to work with our colleagues and get those answers, but also really have a focus on HIV and now, of course, other infectious diseases, including COVID, including hepatitis, and all the other comorbidities that HIV has. Those other diseases, whether they be a result of HIV or only making the HIV that much harder to treat.
Great. Yeah, that's really appreciate that reflection on the work of MAPRI. And I know recently you worked with other members of IDSA and the HIV-MA to update guidelines for care of patients with HIV, specifically primary care. So I thought we could spend a little bit of time today just talking about that and how primary care for patients with HIV has evolved, and what patients need to know, what physicians need to know, both infectious disease and primary care physicians, about quality of life and the problems now that our HIV patients face, which are very different than what they used to.
Very true. Patients from some research from Kaiser Permanente, patients that get diagnosed today, assuming they're working closely with their HIV specialist, you, me, and working also closely with their primary care physicians, they're expected to have a lifespan similar to that of someone who wasn't infected, with the caveat that those patients, though, are likely going to get comorbidities, these other co-infections, at a much higher rate and at an earlier time in their life than patients who don't have HIV. So primary care has to be involved a lot, and it's very different than it was. We're recognizing now that a lot of the communities at risk, African American, young gay men, the transgender community, have had a well-deserved certain amount of skepticism of the medical community and the care they derive. So rule one, first thing that's now new in the guidelines, is about creating a welcoming environment for patients impacted by HIV, so that they will retain care, that they will come back, that they will follow the physician's instructions and recommendations and get the care they need. We talk about the importance of a multidisciplinary care team. So it's not just you and me, but it's our nurses, our clinical pharmacists, our benefits coordinator, our social workers, and our other specialist colleagues, as we need to call on them, plus primary care. This is very different than when it was in the 80s, 90s. The problem is some of those misconceptions of HIV care and the health systems persist. So we've got to go out of our way. I think some of the other areas that you know so well, and I'd love to hear your thoughts on this, is those initial visits, even in times of COVID, creating those human connections, and then really a very full medical history a very full but welcoming discussion of sexuality, sexual behaviors, the things that may have put the patient at increased risk for HIV, that really head to toe, in-depth physical. And then, of course, appropriate labs, initial things. I'd be thrilled to hear how you sort of organize it these days.
Yeah. So, really excellent points. And I think the key is that, now when I see a new patient, you're right. The first and most important thing is to build trust, and for the patient to understand, number one, that we're a team, we're going to work together, we're going to get them through the initial hump of just accepting the diagnosis. I think that is a big initial hump. So patients who can accept their diagnosis do so much better than the ones who remain in some level of denial. And so trust is key to helping a patient accept their diagnosis, and then also making sure that they understand that there are still a lot of misconceptions out there about how well you can live with this disease. And so one of the first things I always do in the first visit is make sure, no matter what stage they're coming to me with, even if they actually have AIDS, to reassure them that we're going to get them through this, and that in the end they should be able to live a very normal life with a normal life expectancy, but they do need to follow through with their care, to come to their appointments, to take their medication. And so that's a critical piece of it. But the other key thing that you said, which is so important, is having that open dialogue, and also asking a lot of open-ended questions, because it's pretty amazing sometimes what you learn when you just ask the right questions and you give the patient the space to tell you things. And oftentimes it's not even in the first visit. It's like the second or third visit that you better understand what their initial risk was and what some of their ongoing potential, risk is, and even what are some of their barriers to care, and so as I'm talking, I'm thinking about specific patients and things they've said, and how enlightening it can be, and how it can really help you take better care of them when you understand what's going on in their everyday life, in their world. It makes a big difference.
It's interesting. That's been one of the, although a challenge, actually one of the great things about virtual care and COVID is you're meeting them in their natural habitat, where they live, and you're getting to experiencing them in their home. One of the things after a while is saying things, noticing things in their home, and asking them to tell the story behind that. And because sometimes we're not always at the medical center, the same thing in our homes, it's really building a much more trusting relationship. But I also think some of the other issues are some of those other misconceptions. You can have children if you have HIV. You can safely be pregnant and be the partner of someone being pregnant. You can do hormone replacement and have the surgeries related to HIV. In fact, I'm going to keep talking about the research that we've done here in KP with Kaiser Permanente in HIV. One of the first studies I did in HIV was showing that for patients with that well-controlled viral load, not even having a very high CD4 count, which is, of course, how we measure your immune system, all those patients can go through any surgeries safely. And that was really important, because getting our surgical colleagues to understand that this is, universal precautions, but then your patients will have good recovery, good outcomes. In fact, as you know, we now even do transplants among our patients impacted with HIV. That is such a different world than when we started in medicine. And it's really some of the key elements of, even in these guidelines, is really reassuring folks of the things that aren't an issue. I also think it's really important, that we do talk about some of the nuts and bolts. So I was wondering, I mean, one of the things we really talk about a lot in the guidelines is vaccinations, and your thoughts about that, especially in this era of COVID.
Yeah. So, I mean, it's something that I think we pride ourselves on at KP, making sure that all our patients follow through and get the recommended vaccinations, especially the pneumococcal ones, and even the meningococcal. So it is, and what I find is that patients, once they trust you, they're willing to follow through and get vaccinated. And I think we can prevent a lot of morbidity and hospitalizations, because we know pneumonia can be very common in HIV, so that's a big one. I think now with COVID, certainly, we're getting a lot of questions about whether the COVID vaccine is safe in patients with HIV, and it's a really excellent question. I'll go to you first for your thoughts on that, and then I'll reflect as well.
So there isn't enormous data yet. But we do know from the main studies for the Moderna vaccine, for the Pfizer vaccine, there were some patients who did have HIV. They were all found, the vaccine was found to be safe. If you really, what we don't know yet is, do they achieve that same level of immunity that patients who do not have HIV had? But that's the same question we're having on patients who have cancer, who have other immunologic or rheumatologic diseases like lupus, like chronic rheumatoid arthritis. Nonetheless, it's safe, and you shouldn't hold off on it at this point. And yes, I am strongly recommending it for my patients.
Yeah, so that's
Your
exactly
thoughts?
the approach that I've taken, and the discussions that I've had with my patients is that we're not questioning the safety of the vaccine in patients with HIV. It's more about really understanding the true efficacy and ability to develop immune response. So while they should get the vaccine when they have the opportunity, and but still continue to take precautions, since we still have some unanswered questions.
Absolutely. It's those, what we call in
Yeah.
medicine, the known unknowns. The other
Yeah.
thing that I think
So
we
a couple
should
of other key things is
go on.
oh, no. Yeah, I was just going to say that I know you and I both are huge proponents of universal screening. I think we should just spend a couple minutes on that, especially because February 7th is National African American HIV Awareness Day. And we know that in communities of color, especially, this disease is unfortunately prevalent and stigmatized. Yeah, do you want to share some thoughts about that,
Yeah,
and the role
I
of
think
primary care in that piece? Yeah.
this was one of the big battles of the late 2000s and the teens, was really convincing people that getting an HIV test should be a normal part of healthcare. It took a long time even to get the U.S. Preventive Services Task Force to say it's an A-level recommendation. At least once get the HIV test, and then if you're at increased risk, more frequently. That was a really hard thing, and it's still a hard sell to the community. But I will note that, like, when we have this project about outreach to an underserved zip code community in Baltimore through also the use of the barber shops, the hair salons. One of the most requested tests was in fact HIV screening. So I think the knowledge of that is improving. It's not moving as fast. And, there also has to be with it a certain, as we've been talking about, comfort of talking about sex with your patients. talking about safer sex, and really, but also talking about pleasure, pride, really parenting, as well as pregnancy, and what are people's goals in life. Sometimes I think people think, if I don't know, it can't hurt me. Well, in fact, that's the exact opposite. What you don't know can hurt you, and worse, can also hurt the ones you love.
Yeah. And, on that note, one particularly vulnerable community that we should spend a couple of minutes at least reflecting on and talking about their specific care, and an area of your expertise, again, is the transgender community. Any specific advice on how we should best engage them and care for them? And, one of the things that we both know is the discrimination that they continue to face in the healthcare system.
It's so bad, so hard. Sometimes we are our own worst enemies. Sometimes the medical community, even by offhanded remarks, really also imposing our own values upon others outside of medical care. The transgender community, the community on different pathways of both gender self-realization and informing others and how to achieve your goal, is going to have multiple unique paths. Having said that, and knowing that for a variety of reasons, many of these patients, especially transgender women, male to female, have been at increased risk for HIV. Nothing biologic, mostly related to social and economic situations. As a result, it's really important that you incorporate their gender pathway to how you're delivering the HIV care. There are some things, especially as you talk about hormone replacement, that or hormonal therapies, there could be potential drug-drug interactions that you got to be aware of. That doesn't mean you don't do it. It means you just got to be aware, work closely, let's say, with the endocrinologist or with their primary care physician who's maybe WPATH certified, which is one of the processes. It's also important, as we talked about earlier, if the viral load is down and the immune system is stronger, their surgical pathways will also, HIV won't be a concern in their surgical pathways. So all that's really important. But again, it gets back to the same things we've been talking about for these last few minutes. Creating a welcoming environment, really asking all the questions possible. Patients are not most often are not insulted by asking these questions. They'll say, well, that's not applicable to me. But if you note that I ask this of everyone, and you really do ask it of everyone, no one's offended.
Yeah. Agree. I think if you ask in the right way, and you, I always offer up a little bit of personal information about myself, like my training, why I'm doing HIV care. That always kind of makes patients feel a little bit more comfortable, and that, you've been doing this for many years. You've gotten many people, you've taken people who've been diagnosed and have had a hard course up front and gotten them through, and they're living full lives. Helps and puts people at ease. And sometimes I even use the words, I'm not going to judge you in any way. You can tell me anything. This is just an open dialogue. So I often sometimes just have to say that if I sense that the patient has not a great level of comfort. So
yeah, no, I think,
yeah. And so
I think
one
calling it
other,
out,
I think, oh, go ahead.
I think
Sorry.
calling it out really is essential. The one other thing that I think we should know before we end, I don't think we've had a chance to talk about, is the fact that in many respects for these patients, HIV is probably one of the key health issues they have, but it may not be the only health issues with the comorbidity. So in many respects, primary care, the HIV specialists are really going to end up having to, I hate to use a football, I'll use it, is quarterbacking the team and really understanding, creating that game plan. And so it's really important that just because a patient has their HIV under really good control, you can't not pay attention to the other things, including, I always mention it, stopping smoking, being careful, checking for diabetes. We used to only worry about anorexia and really underweight, but now we know obesity is becoming a major issue among the HIV community too. So these are other things we have to talk about. It just means HIV is complete total patient care.
Yeah, exactly. It really is. And it's actually one of the reasons that I enjoy it so much. But you're right that it takes a team effort, and it takes the primary care physician, the HIV expert, the ID physician to really work together. We're lucky within Kaiser Permanente to have an integrated health system where it's really easy to do that. But I think it's really important to have those connections and to continue those dialogues, because a lot of times what I find these days is my patients who've had HIV for many years, diabetes, their chronic renal disease that is now impacting my ability to give them the simplest HIV cocktails, because we have to tailor it based on their other diseases and comorbidities and things that are happening. And so managing those are just actually key to be able to keep
Definitely. Yeah,
HIV medicine as well
definitely
as
hear you
possible
about that.
for adverse effects.
Definitely hear you about that. And making sure that the patients can afford and get their medicines safely and continually. Absolutely. The social determinants of health are now becoming such a critical issue with patients with chronic conditions like HIV. It's so, so important.
Yeah. And so I think one good note to end on is the whole concept of U equals U, which I think is out there, but it's not out there as much as it should be among physicians or patients. It's such a critical and important piece. So I don't know if you want to spend a little time on that, Michael, and what that really means for our patients, our physicians, our community.
It's so, so incredible. Basically put, if the viral load is undetectable, it means you can't transmit, the patient can't transmit HIV to others. Undetectable equals untransmissible. That is such, for so many patients, a big driving force as to why they should be adherent to their medicines, why they don't want resistant virus in their system, and why you need to control that virus. But it's so liberating to patients that when they have it, that even if they're not engaging in classical, I'm just going to use that term there, safer sex, it's still safe from the perspective of HIV. Now, we will always have to remind them, you can still get a lot of other STDs and a lot of other health issues, even when your virus is undetectable. But it is so important to the community. It's one of the ways we will break the HIV pandemic. And Mona, you seem frozen. Obviously, the computer got a virus.
Yeah, thank you.
So maybe I'll just, well, I think you're back. I just want to say thank you. This was a great conversation.
Yes, I'm back.
And I love having you as a colleague and friend.
Yeah, thank you, Michael. It's always great to talk with you. And so hopefully everybody was able to learn a few things today. So thank you. All right.
Thanks.